Hello, thank you very much for your kindly invitation to participate in the Moscow Congress. I'm very happy to be here. We are going to talk about the endovascular treatment of the distal cerebral vascular occlusions. You know that the highest level of evidence of the thrombectomies for the treatment in the M1 segment of the medial cerebral artery, and for the M2 and M3 segments, and also for the ACA and ACP arteries, the level of evidence is only at 2B. But look, it's the same level of evidence that we have for the treatment of the occlusions in the basilar artery. And we know that the occlusions in these arteries can be also very important. An occlusion in the M3 segment can give the patient an hemiplegia, aphasia, neglectemy, anopsia. In the anterior cerebral artery, aphasia, mutism, hemiparesis, or in the posterior cerebral artery, thalamic devastating syndromes, including aphasia or hemianopsia. So, should we treat these patients? I'm sure that we should. In this interesting paper of last year's published in Stroke, they took two important trials and they put out the patients treated with endovascular treatment. So they analyzed a total of 258 patients with medial vessel occlusions strokes treated also only with intravenous alteplase. The median NIH of the patients was 7, and the conclusions are really very interesting. 50% of the patients in this study did not achieve excellent outcome at 90 days with the best medical treatment. So the medical treatment maybe is not enough in these patients. 33% of the patients were not functionally independent. And the recanalization on follow-up imaging wasn't strongly associated with favorable outcomes, but was only achieved in 47% of the patients, in spite of the treatment with intravenous alteplase. So in the conclusion of this study, they say that maybe endovascular treatment should be explored as an alternative treatment option. In the editorial of the same number of the stroke, they encourage us to start with randomized clinical trials for evaluate the safety and efficacy of the endovascular treatment in this medial vessel occlusion stroke. Professor Goyal and Professor Hill give us some clues very interesting in this paper called MIVO, the Next Frontier. And I think this is very important because we are not talking only about the anatomical things, not only about the segment M2 and 3, but we have to talk also about the functional. Maybe we don't have to treat every M3 occlusions, but because we have to assume some risk. So they put the clinical level in NIH 5. So they think that we have to treat occlusions in these segments in patients with an NIH of 5 or more than 5, and below 5, maybe when they have disabling deficit, for example, an aphasia. And I agree absolutely with this paper. But we have to know what is the M2 segment, and sometimes we are not all we don't talk all about the same thing. So in this paper, I think they give us some clues for that, and of course the M2 segment is coming from the main MCR bifurcation or trifurcation to the circular sulcus of the insula. But we have to take into account all those variants that we have here, and we have to know them, of course. In the PROMISE study, there was a study published with the analysis in a multi-center European study analyzing the treatment with direct aspiration with the Penumbra catheters. We do an inter-analysis of the patients treated with the N2 that we published last year, and we can see that the treatment is as safe and as it has the same efficacy as in the N1 occlusions. And in this interesting paper, they give us another clue that is important, because maybe we don't have to talk only about distal. We have to talk also about the diameter of the artery. So they talk not about MIVOs, they talk about the MVOs, distal medium vessel occlusions, because we are talking about arteries that are more distal, have more branches and more tortuous, and have a diameter between 0.75 and 2 millimeter. And we have treated always some distal occlusions when we have a distal embolization of a proximal occlusion. As for example, in this case, we have an N1 occlusion. Here we have the occlusion. We treat it with a jet 7. The jet 7 is there. We do direct aspiration, and after one pass, we have opened the N1 and 2, but we have a distal emboli in an M3 segment, anterior segment. So as we have here, the jet 7 in the N1 is very easy to go up with the 3 max that we have used before to navigate the jet 7, and we go directly with the 3 max and a macro guide wire, and we do direct aspiration as in the M1 segment with the jet 7, but here with the 3 max. And we open this M3 and look, it was a huge clot. The puncture was a 1628, jet 7 pass with 1649, and the TK3 finally after this M3 recognition at 1654. Look at the just 5 minutes between the treatment in the M1 segment and the treatment in the M3 segment. And this is a 24-hour CT. So we talk sometimes in this secondary distal medium vessel occlusion, but we have to talk about the primary distal medium vessel occlusion. So we have some problems here. There's a lack of definition and level of detail of the prognostic scale. So maybe the NIH and MRS scales that we treat with for the large vessel occlusions is not enough here. There are some disabilities that are very important and that are not registered in these scales. It's also true that the development of the alternative treatments, like the nectecplaza, maybe is better than the alteplasa, and the efficacy is bigger here in these distal vessel occlusions. We have to look for it. There is a difficulty in the diagnosis and lack of ability to detect MIVOs. The correct anatomical clinical correlation maybe is sometimes not so easy, and the occlusion is accessible endovascularly, sometimes yes, sometimes not. We have to look for it in the angio-CT before treating the patient. And also some scales like the aspect is not as useful here in distal vessel occlusion, so we have to look for new aspects and new TG scales in these distal medium vessel occlusions. It's true that sometimes it's not easy, even in the angio. So sometimes you are to see the occlusion, where the occlusion is. So sometimes it's good to do the injection, the N1, and after doing this injection, we wait for the late venous phase, and that sometimes in that moment is easier to see where the occlusion is. We go there with the 3 max, we do direct aspiration, and this is after the aspiration. And we have some more problems. There's a low availability of suitable devices. It's true, we don't have a lot of devices for distal occlusions, and sometimes the treatments are more complex. This is how I treat normally most of the strokes. I go with a long sheath, normally the Neuron Max, then the Penumbra Jet 7 or Jet D, and I navigate normally with the 3 Max and a micro guide wire. If I go for a proximal, I go with a Jet 7. If I'm going for a distally, I will treat it with the Jet D or with the 3 Max, but I always go with this pack because I use the 3 Max to navigate the Jet D distally, or I use the support of the Jet D to navigate more distally the 3 Max. I'm going to show you now all of these things. Look, for example, here it's not easy to see where the occlusion here is, so we wait for the late phase, and then we see this distal M2 in the lateral view. Also, it's important to work always, if we can, with the two angios, yes, and here we navigate with the microguide wire distally. And then we have in the M1, distal M1, we have in this case the Jet D, and we navigate the 3 Max through the microguide wire, and there, of course, there is some rectification of the artery, and then we have there the 3 Max. Always the clot is a little bit further down where you see the occlusion, the stop of the contrast, and we are there. We aspirate. I like to aspirate through the pump, and after 1.5 minutes or 2 minutes, here is the clot, sometimes like this in the tip of the microcatheter, and this is after complete recanalization. This is another case, a distal M2 occlusions, and this is why I do like a lot aspiration here more than stent retrieval. Look, here we have the 3 Max. We aspirate with the 3 Max, and after aspiration, I want you to see what did we have after the occlusion. If we pass this occlusion with a stent retriever, I'm sure that we were going to have some problems. So here, distally, we have more branches, we have more elongations, and this is more risky, of course. Sometimes we have occlusions in different arteries, and we have to choose the best catheter in each case. In this case, it's an old case, I went with a ACE60, it's like a Jet D here for the distal M2, and then for the ACA, I went with the 3 Max. Here we have the complete recanalization. Or sometimes we have even more. We have an M2, an M3, and an ACA. Sometimes after the intravenous treatment, we have these problems and the distal emboli, and we go here with in this case was at A68. Then here we went with the 3 Max, and here with the 3 Max also. So this is after A68 in M2. Here is open. Here we went for the 3 Max to this distal M3. This is after the recanalization of the M3, and then after recanalization of the ACA. We have a distal M2 here, left M2, and I want you to see that we have a Jet D in M1. We have the 3 Max just in front of the clot. We have passed with the microguide wire, and you can see that maybe the 3 Max is a little bit small for this artery, so I used the 3 Max as support to pass the Jet D to the clot. So here Here we have in the lateral view, and we have passed with the GD to the clot. We aspirate the clot with the GD, and this is after the aspiration of the clot, complete recanalization, as you can see here in this video. In this video, I'm going to show you another case with an NIH of 10. We have another distal M2. This is the lateral view. Here you have the occlusion. So as I told you, we navigate with the 3 max. We have the 3 max in just where the clot is, and we go with the GD through the 3 max. We navigate very smoothly, and this is after the aspiration after one pass with the GD. Here was the clot inside the GD, and 19 minutes for the complete recanalization. This was the clot, and this is the CT the day after with NIH of 1. Another case, this is more distal, and we are going for M4 for a patient with aphasia. We have to wait for the late phase because, as you can see, maybe you see that here the occlusion is in distal M2, but no, it's not true. It's not true. The clot is more distal, so we have to, if we aspirate in M2, we are not going to achieve a recanalization. So we have to go where the clot is. So we go with the 3 max, we navigate very smoothly, and here after the recanalization, I see that it was really an important artery. Complete recanalization. This is a recent case. We were with another stroke in our principal angio. We have to go to the old angio, and this is a patient of 61 years old. Was under oral anticoagulants after a stroke that we treated last year, and one he recovered perfectly, and he had another time another occlusion. In this time was a distal M2 with an NIH of 2, but with aphasia. So we go there with a 3 max, and this is after the complete recanalization, and the patient recovered perfectly. So in the posterior cerebral arteries is the same. We have to treat these patients. We have only a 2B level in the basilar, so are we going to go further? I think that yes, sometimes we have to do it. We have participated in this topmost study, and it was a huge registry of P2 and P3 treatments, and we found that it's reasonably safe and technically feasible to treat these patients, especially with high NIH, higher than 10, or with the patient is not eligible for intravenous treatment. Here we have a P2 clot treated with direct aspiration with the GD also. And this is a case of internal carotid artery, a T carotid occlusion, that the patient has a posterior cerebral artery arising from the internal carotid artery, a fetal, posterior cerebral artery. It was occluded also in a distal P2. So we treated with a jet 7, with one pass of jet 7, the internal carotid artery, and then we went with the 3 max to treat this distal posterior occlusion, but we couldn't achieve a recanalization with the 3 max. Maybe there was a curve after, and I was not impacting properly the 3 max. It was not able to impact properly the 3 max in the clot. So as I was there with the 3 max and with the guide wire, I decided to pass this to the posterior cerebral artery with the GD. What for? To do aspiration distally with the GT? No, in this case not, because it's too distal to navigate with this huge catheter to the GD. But if I have here the GD, like this, in the posterior cerebral artery, it's easy to navigate, retiring the 3 max, navigate with the microguide wire, microcatheter, and pass a stent retriever here. We have the stent retriever in the posterior cerebral artery, and we do a treatment as Penumbra here. So here you are going to see that the stent retriever and I'm retrieving it. At the same time, I'm aspirating through the GD. So if I have an emboli here, the emboli is not going to go to the internal carotid artery again or to the medial cerebral artery. And this is a efficacy treatment when I cannot do a direct aspiration in a distal artery. This combined treatment is really very good, and here you have the control after the run, after the complete treatment. So this was all, but I hope that we have some time now for a debate. I will have it for that. Thank you very much. Muchas gracias. I hope to receive you in Madrid sometime. I will be very happy for that. Here you have my email address if you have any question also later. And stay safe. I hope the next photo will be without this mask. Thank you very much. Bye-bye.